Hi everybody, and welcome back to a lecture on the respiratory system. So this is chapter 22. So there are a number of different functions for the respiratory system. The obvious walking into this comment is that your respiratory system is going to be involved in the movements of oxygen and carbon dioxide. The nature of it is that as I breathe in, I'm trying to get oxygen. Then when I exhale, I'm releasing carbon dioxide. These are byproducts of my metabolism. So we do aerobic cellular respiration. It's how we make our ATP. So when I breathe in, I'm trying to get oxygen to fuel my mitochondria to make ATP, and I'm exhaling carbon dioxide as a byproduct of that metabolism. So your respiratory system most certainly plays a role in the exchange of oxygen and carbon dioxide, but there are a whole host of other things playing a role here. Serving as the basic centers for speech and other general vocalizations. So your respiratory passages include your oral openings, include your larynx and your glottis, which allows you to make sounds. Again, think about the concept here. I can speak to you without vibrating my vocal folds, and you can still hear my whispers just with my mouth making shapes. But alternatively, I can vibrate my vocal folds and you can hear me far better. Okay, so this is a role that is played by your respiratory system. It's going to be involved here. Your sense of smell. So the upper portions of your nasal canals, your upper nasal openings, if you will, are going to play a role in your capacity to smell things. So smell is definitely going to play into respiration. Again, you are well aware of this. We hunt things down in our living areas by smell. It's very important. It's a good way to tell if your kid's been up to something they're not supposed to be up to. Moving on. Affecting bodily pH. So carbon dioxide does something important in your bloodstream. It turns into carbonic acid. All right. The nature of this is that it drops your blood's pH. So your blood's pH is supposed to be about 7.4. Well, you can drop that by having a buildup of carbon dioxide. And when carbon dioxide builds up, the blood gets a little bit acidic, or more acidic, I should say, and loses oxygen carrying capacity. So the whole body pH variant is going to be dealt with in part by your respiratory system, ridding the body of carbon dioxide and thus bringing your blood's pH and your whole body pH as a result back into equilibrium. Affecting blood pressure. So there are hormones that play a role with the respiratory system that can play a role in blood pressure. That's a fact. Number 6, breathing creates a pressure gradient. Okay, so remember our respiratory pump when we're talking about moving venous blood back to the heart, and the same kind of story is played with your lymphatic system. So the movements of lymph back into your major veins is going to be using this respiratory pump as well. So I'm going to take deep breaths. I'm not only pulling air in, but I'm also moving blood. So your respiratory pumps are very important, and it's part of your respiratory system. Then last but not least, this concept called the Valsalva maneuver. Okay, so the Valsalva maneuver can take on a few different roles. Let me see if I can explain this to you. So go and look this up. The gist of this is that you can kind of sit down, lay back, take a deep breath. Don't do this. Take a deep breath, then cover your nose and put as much pressure as you can, really force, and then exhale forcefully. And it, in essence, will reset your heart to some degree. And if you are going in like tachycardia, if your heart rate's too fast, you can bring it back down. You can reduce your heart rate using this Valsalva maneuver. Valsalva maneuver. But the same idea, no pun intended, also plays into holding one's breath and clenching the abdominal muscles in the way that I just described. Also helps us expel abdominal contents. Go to the bathroom in various ways, birthing a kid. It's all the same concept. You're pushing out. And to do this, we take a deep breath and we fill the chest cavity with air, which takes up all the space. And then the diaphragm is distended because that breath is fully in. And then we flex the abdominal muscles, and anything there that can move out is going to move out. That's the idea behind this, the Valsalva maneuver. Worthy of your knowledge. And again, go and read about this. This is the strangest thing. And the way it's used for dealing with blood pressure and heart rate, I should say. It's kind of neat. So look it up. It's kind of neat. Overview of the respiratory system. So here is a good run through of how everything looks and how everything works. We will divide things up into the upper respiratory tract and the lower respiratory tract. So your upper respiratory tract is going to comprise your nasal cavity, right up here. It's going to be very important for filtering air, warming it up, adding moisture. Works. Your pharynx, which has 3 parts, which is back here, right? And the pharynx, interestingly, is going to be the area where your esophagus and your respiratory passages, so the path of food and the path of air, this is the only place they mix. Okay, it's right back here in the pharynx. So the pharynx plays a role both in your respiratory system and your digestive system. You need to be aware of this. And again, 3 parts. So we're going to talk about all 3 parts. The glottis, which is going to be right in here. Right, the glottis in here right above the larynx. This is going to be part and parcel with the way in which we vocalize. So your vocal folds are going to be right in there at the glottis. And then the larynx, okay, going to be below right in here. So the larynx is oftentimes referred to as your voice box, all right? Yeah, that'll do. It's close enough. So here we have an interesting question. Is the larynx part of the upper respiratory tract, or is the larynx part of the lower respiratory tract? And I'm here to tell you that your book says that the larynx is in the lower respiratory tract. I have never seen that before in my life. I have always read and been told and learned that the larynx here is going to be involved in the upper respiratory tract. But you got to keep in mind that this is just us being human and liking to put things in little boxes, and they don't always fit neatly into little boxes. For my purposes, the larynx is upper respiratory tract, and the trachea is the first part of the lower respiratory tract. So classically, the trachea begins the lower respiratory tract. So the trachea is here. All these cartilaginous rings, a big open tube about 1 inch in diameter. This is a big air passage. Okay, it's going to let air down. This comes down to bronchi of various forms. Okay, there are a number of different bronchi, bronchi. These are the smaller than the trachea, but the largish air passages in the lungs. You'll see what I mean by this here in a little while. That will terminate at the very tips down here into bronchioles of various sizes. And the bronchioles lead down to your alveoli. And the alveoli are incredibly important. Okay, the alveoli are like the little air sacs in the lungs that allow us to conduct gas exchange. Okay, so where does gas exchange happen? Well, that happens in the alveoli of the lungs. And then last but not least, and sort of included in all this, is the diaphragm. The diaphragm is indeed muscle, and it's going to flex by pulling down, and that's going to pull air in through your nasal openings in your mouth and allow you to breathe. All right, now, you need to know the pathway that air takes as it comes into your system. And that's going to run something like this. You breathe through your nose. Now, you can breathe through your mouth too, but you are set up to breathe through your nose because you want that air warm and filtered and moist. Okay? So you're going to breathe in through your nose. It's going to come down your pharynx, through the larynx, into the trachea, into the bronchi, into the bronchioles, and all the way down to the ends, into the alveoli, where air exchange takes place, oxygen and carbon dioxide. So that, folks, that's how this is done. And let's see, what else do I want to say here? Oxygen and carbon dioxide are exchanged, that's true. And I will point out that the exchange of oxygen and carbon dioxide are wholly based off of diffusion. This is a simple diffusionary mechanism. There's nothing fancy happening. You just put oxygen in close proximity to the blood, and it's going to diffuse into the blood. You put carbon dioxide in close proximity to the outside air, that carbon dioxide is going to diffuse out of the blood into the outside air. It's just how this works. Okay, it's simple diffusion. All right, so let's go into a little bit more detail on all these parts and pieces, shall we? First, the upper respiratory tract. We're going to start with the nose. Again, the nose is kind of a neat thing here. The nose has a variety of functions. We're going to warm the air up. We're going to clean it. And we're going to humidify it. What kind of air is that English? What kind of air do your lungs like? Your lungs like warm, moist, clean air. And your nose is specifically set up to condition the air you breathe to get it where it needs to be. Now, that's not all that's happening here. We're certainly going to detect odors using this upper, what's called a nasal concha, and we'll be talking about those here in a little while. And further, The nose and the sinus cavities that are here certainly do serve a role in the resonance of your voice. So I can talk to you, or I can close my nose and talk to you and sound very differently. So the resonance of our voice is also going to play a role here with the nose. Now, inside of this nasal cavity, there are piles of capillary beds. I mean, it's just awash in capillary beds. And what that does is it helps with that warming of the air that's there. So air comes into very close contact with the blood, but here we're not trying to diffuse oxygen. We're trying to just warm the air up so that when it gets down to the lungs, it's conditioned. All right, your pharynx has three parts: naso, oro, and laryngeo. Okay, nasopharynx by the nose, oropharynx by the mouth, anything oral, oro, and then the laryngopharynx down here by the larynx. I will point out a few things. I think I cover this later on, but I'll point it out now. Up here, all this is going to be pseudostratified epithelium. This is stratified squamous. So this is not necessarily a protective epithelium, but all this is. Okay, this is the same stratified squamous that you got on your hands and your feet and whatever. It's just got a lot less keratin. It's considered non-keratinized stratified squamous. It's many layers thick. Why would you have a tough lining back here in the larynx? I'm sorry, in the pharynx. Why would you have a tough lining back here in the pharynx? Because, you know, think of all the foods that we eat, and it's going to be running through here trying to go down the esophagus, where we're sending food down to the stomach. All that rough material and tough stuff, it's got to hit back here, and this needs to not be damaged by it. So your pharynx, specifically the oropharynx, is stratified squamous epithelium to make it a little bit tougher so that when we're eating, it doesn't get damaged. Yeah. And I'll point this out too. You probably are aware that you can look in the back of your throat and see a little thing dangling down. It's called your uvula, okay, the uvula. And this is part and parcel with your soft palate in the back of the throat. And what will happen is when you swallow, a few things take place. One, when you swallow, your epiglottis, which is a little elastic cartilage fold, okay, the epiglottis will come down and cover the tracheal passages. So I've got food in my mouth and I swallow. This piece here comes down and covers up the openings to my tracheal passages. So when food comes down, it goes down the esophagus and not into the trachea. And further, this uvula moves up and sticks to the nasopharynx so that as you swallow, stuff doesn't go up your nose. Now, is it possible for you to eat something and go down your trachea? Sure. Is it possible for you to be doing something and it accidentally goes up your nose? Sure, but it's a rare event. And when it happens, normally you're coughing up a storm and trying to deal with it in one way, shape, form, or another. All right, I think that'll do. The larynx. So the larynx down here, this is going to contain a lot of hyaline cartilage. So all this is going to be supported by hyaline cartilage. We're ignoring the epiglottis here, again, which is made out of elastic cartilage. It's far more flexible. So you can feel your larynx through your throat, and it's very tough. That's hyaline cartilage. Whereas the epiglottis there, again, is the same kind of cartilage as your ears. It's elastic cartilage. And it's inside of this larynx that we find these vocal folds. Okay, your vocal cords or vocal folds, all part and parcel with the glottis. If I were you, I would pause this video and I would look up this video and view some people singing and what their vocal folds do. It's a very fascinating thing. You're never going to guess what these things look like. It's super neat and worthy of your time, so you should do that. All right, the nasal cavity. So let's see, what do we want to say here? You obviously need to realize that you got two sides to the nasal cavity. So there's a connector in the middle, a big barrier, if you will, that separates these two sides, this nasal septum. And on either side, there are what are called nasal conchae, or what are oftentimes is called the turbinates, of which there are three of these: superior, middle, and inferior nasal conchae. It's the superior nasal conchae that has your olfactory epithelium, and that's going to give rise to your capacity for smell. Now, let's talk a little bit about these. All of these turbinates and things are there to help spin air, and this is a environment that has hair and a lot of cilia in there, and the nature of it is, again, with the nose, we breathe through our nose, we're trying to clean that air up, we're trying to warm it, and We're trying to get it moist so that as it comes down to the lungs, it's been conditioned to function correctly. Up in this area, again, this is pseudostratified columnar epithelium. Lots of goblet cells. That's how your nose produces the mucus it produces, is because the goblet cells. And interestingly, there's a good bit of erectile tissue up inside the nose as well. So what happens is kind of neat. Imagine if you're sitting there breathing through your nose progressively, that your nose could dry out a little bit from all that air moving through. What will happen is, if you will notice, breathe through your nose forcefully, you'll notice that one side kind of works better than the other. And in about an hour, it's going to change sides. The other side's going to work better than that one. Then another hour, it'll swap back. What we do is we kind of alternate sides of the nasal cavity so that we don't overly dry and thus damage our nasal epithelium. So there's erectile tissue in there that will swell up and kind of block off part of the nose, and then it'll go back down to normal and the other side will swell up, and it kind of lets us alternate which nostril that we breathe through about every 30 to 60 minutes, somewhere in that neighborhood. It's kind of a neat process. Yeah. What constitutes the lower respiratory tract? So we got our trachea here, and the trachea is very, very, very important because it is lined with these pseudostratified ciliated columnar epithelium cells. Lots of goblet cells that produce mucus, lots of cilia. Now let's remember that your oropharynx does not have this same tissue. You find that tissue up here, you find that tissue down there, but this is all going to be stratified squamous to make it tough. Alright, so let's see what all do we want to say here. So this is the trachea. It's going to come down and terminate into bronchi of various forms, which we're going to talk about a little bit later. All of this is lined with rings of cartilage. Okay, there are hyaline cartilage rings there, and they're, again, lined with mucus and cilia. These rings are not quite fully rings. They're actually kind of C-shaped, if you look here. I'm going to be talking more about this as we progress, but the nature of it is as follows. This cartilage holds the trachea open, so when I take a forceful inhaling moment, when I take a deep breath, I don't collapse my trachea. All right, there's a lot of negative pressure that builds up when I take that deep breath, and those cartilaginous rings hold the trachea open so it doesn't collapse in. Think about like if you had a straw and you held one in and you sucked through it, you could collapse that straw. We want to prevent that, and the way we prevent the trachea from enclosing upon itself is by having these cartilaginous rings. And rings as being, you know, not quite correct. Again, they're really C-shaped. The reasoning behind this is we have a membranous area on the back of the trachea, okay, where it meets the esophagus, and the reasoning is so that when you swallow things, nothing is raking down these cartilaginous rings. It's a soft, fibrous backing here, so that as you swallow, stuff can move down the esophagus without really grinding into the cartilage of the tracheal passages. And there's more to it than that, but that's good enough for now. Let's see. So we've got our bronchial tree here. Bronchi, bronchioles, alveoli, bronchi. The bronchioles will be way at the ends, and then the alveoli are little bitty air sacs. So that will be a bronchiole, and these would be air sacs. These are the alveoli. And what happens is the cardiovascular network is just completely interwoven with these alveoli. So you get these little air sacs, and they're completely covered in capillary beds, and that's going to assist us in having the ability to absorb oxygen. Now, the lungs themselves look like this. The right side of your lungs, okay, the right lung has 1, 2, 3 lobes. The left side has 2 lobes. They look different. They're moved in different ways. They're at different heights. There's a lot going on there, so we need to talk about it. First thing we're going to do, though, is we're going to talk about the trachea. So again, the trachea is supported by a bunch of cartilaginous rings. They help hold the trachea open as you're breathing. They are C-shaped. They're not fully rings. They are C-shaped. This does help when you're swallowing. So as food moves down the esophagus, it's not raking against cartilage here. It's got this fibrous backing so that food doesn't rake against cartilage. It runs down this fibrous backing there inside of the esophagus. This helps hold the air, the trachea open, okay, the windpipe open, if you will, while we're breathing. And by having these open rings with gaps in between, it allows you to turn your head without building up tension with that cartilage. So that's important as well. Again, this is going to be lined with pseudostratified columnar epithelium. This is a ciliary epithelium. And what will happen is, as you are breathing, if any debris gets caught in this, there's what's called a ciliary escalator, okay, a mucosal ciliary escalator. And it's going to push stuff up and out of your respiratory tract, and it will push that material up to the epiglottis, sort of right up at the top here, and you'll cough and jettison that stuff up into the pharynx, and then swallow it down to the stomach through the esophagus. So this escalator, if you will, is going to carry materials up and out using these cilia and keep your tracheal passages clean. That is, unless you're smoking, okay? If you're smoking, then this pseudostratified columnar epithelium, the cilia, become paralyzed, and they don't run material up and out of the trachea any longer. Mucociliary escalator, there it is. And if you smoke a lot, you can actually destroy the cilia. So then you're going to have buildups of potential carcinogens hanging out in your tracheal passages and lead to potential problems. And now, worthy of mention here is a tracheostomy. Okay, a tracheostomy. We call this putting in a stoma, or an opening. What will happen here is, if someone has some kind of crazy blockage upstream, if something's happened to close off their windpipe where they can't breathe, something's gone on and it's closed off above so the person can't get air in. Maybe their tongue swelled up. So anything, you name it. Something is obstructing the airway. What we do is we go in through the neck and we find these cartilaginous rings and we cut a little bitty hole. It's a little bitty hole in one of them. And then you can take your pen and stick it in there and you can breathe through the tube, okay? This is a simple process, tracheostomy. We will open up the throat and put a little hole in there so a person can breathe through it, and it will keep you alive in emergency situations. That absolutely happens. And the reason I mention this is because many, many, many years ago, I was watching a television program and I watched people do a tracheostomy, and it kind of stuck with me. All right, so if you're curious, you can jump on the YouTube. You can type in MASH tracheostomy, M-A-S-H, MASH tracheostomy. There's this old TV show called MASH about a mobile army surgical hospital, and some folks that weren't supposed to be doing the work had to do the work to save somebody's life. And man, I saw that when I was like 10 years old, and I will never forget it. I was like, wow, that's amazing. And I linked the video here, but I don't think it's on your version. Anyway, pretty neat stuff. Like, I hadn't seen it in 20 years, and I went back and watched it before I put this together, and I thought it was worthy of mention. All right, the lungs and the bronchial tree. So, let's see here. First thing I want to do is talk about the pleural membranes. So, you have pleural membranes just like you have pericardial membranes. So, there is a visceral pleura attached to the body wall around the lungs, and then a parietal pleura attached to the lungs like skin on a grape. These are serous membranes. They produce serous fluid. And what this does is allows the lungs to expand and contract, without building friction up on the body wall. So these things can slip around in there and not have damage. Unless they become all inflamed and nasty and mad at you. And that's a condition we call pleurisy. Okay? Pleurisy. This is an inflammation of the pleural membranes. And what can happen is they can rub against the parietal pleura, can kind of friction rub against the visceral pleura, and it provides this crazy sharp stabbing pain every time you try to breathe. It's a painful situation. And further, this can really get to an extreme that can become quite inflamed, and they can start producing excess fluid as a buildup due to inflammation, and the fluid can actually constrict the ability of the lungs to expand. That's a later stage pleurisy, so that's real bad news. We have to go in with a needle and extract the fluid to allow the lungs to then do their work. All right. So your right lung is a little shorter. All right. As a result of the liver, so the liver pushes up on the right lung and kind of, tell me I got a better picture than that. I guess I don't. The liver pushes up on the right lung and kind of makes it short. Okay. And let's see, it's divided up in three parts: superior, middle, and inferior regions, and they are separated by a horizontal and an oblique fissure. Okay, so 1, 2, 3 parts on the right lung. Left lung only has 2 parts with an oblique fissure, and the left side of the lungs, the left lung, has this crazy pericardial notch, okay, a cardiac notch, and that's because the heart kind of sits over on the left-hand side and kind of holds the left side to be a little smaller, okay? So the heart would be sitting right in that notch there. Yeah, that'll do. Man, I wish we had some time. I'd tell you all about some weird diaphragmatic hernias I've seen in the past. Some pretty neat stuff. All right, the bronchial tree. The bronchial tree. So you've got your trachea coming down, and then that's going to become a primary bronchi. Primary branches to form secondary bronchi. Like these are going to be secondary bronchi. Secondary bronchi branch to form tertiary bronchi. All right, tertiaries. And then we go down to the bronchioles. Okay, the nature of it is, as I've always been told, is that you take two tertiary bronchioles, or I'm sorry, that's incorrect. You take two tertiary bronchi and bring those together, that makes a secondary bronchi. Take two secondary bronchi, bring those together, that makes a primary bronchi. Take two primary bronchi, bring those together, and you got the trachea. All right, so that's the order that this runs in. And interestingly, let's make sure we're together. We still have our rings of cartilage here, but then as we get down to like the tertiary bronchi, the secondary bronchi, these become not full C-shaped rings, but more or less just little cartilaginous plates that help hold things open. And then that takes us down to the bronchioles. So these little bitty, tiny bronchioles are about 1 millimeter in diameter, and then they'll further branch to terminal bronchioles, which are like 0.5 millimeter in diameter. So these are very small. The bronchioles are indeed ciliated, so they're going to be using this escalator to push material out. It's a little different tissue, but ciliated all the same. And then these terminal bronchioles are going to move down to form what are called lobules. Do I have lobules on here anywhere? But either way, they're going to terminate in these little alveoli sacs. Okay, the alveolar sacs. That'll do. So we got terminal bronchioles, and then further bronchioles. Let me tell you something. There are a million different derivations of this. For my purposes, I want you to understand that you get your trachea, primary, secondary, tertiary. Then you're going to have these terminal bronchioles that terminate into the alveoli. And I'm pretty well happy with that. I think that's a good way to think about it. The alveoli themselves. So you've got about 150 million alveoli in each lung. And the reason they exist, the whole concept here, is to vastly increase the surface area for exchange. You want to have as much surface area as possible. So you got little grapes, basically. All these little tiny micro sacs, these alveoli, that vastly increase the surface area for exchange of oxygen and carbon dioxide. In fact, the amount of surface area for a decent-sized human adult is about 750 feet squared, 750 square feet. And that is considering that a decent living room is about 400 square feet, okay? So in other words, what I'm telling you is you have massive surface area in your lungs as a result of having these tiny little air sacs. And you may have heard of emphysema, which I'll talk about a little bit later on. Emphysema is a situation where these air sacs break down and you just have one big sac. And that really decreases the surface area so you can't get oxygen into your tissues as well. All right, so we got our air sacs. We know they're alveoli. We know that this is a diffusion-based mechanism. Let's talk a little bit about surfactants. All right, so your alveoli have a fluid coating internally. It's basically water. There's some other things in there as well, including a certain chemical referred to here as a surfactant. This is a family of chemicals that basically decreases general water tension. The nature of this is that this fluid is there so that when you exhale, you can't collapse the alveoli. If they were to even try to close, they would open back up naturally because the surfactants there prevent this all from sticking together. Okay, it's an important concept. And I will also point out the nature of your respiratory membranes. All right, it's going to go something like this. You have this fluid here next to your simple squamous epithelium that lines your alveolar sacs. The alveolar sacs are made of simple squamous epithelium. It's incredibly super thin. There will be a basement membrane that holds the epithelia up. It's connective tissue. You got to have it. It's what makes epithelium epithelium. And then you have the endothelium of the capillary, which is also going to be simple squamous epithelium. So a layer of simple squamous, basement membrane, layer of simple squamous. This is as thin as two tissues can be and still be separate. Okay, so this is an incredibly close contact situation. So as you bring air in, the oxygen diffuses into the blood, and then carbon dioxide from the blood diffuses back into the oxygen. This is referred to as your respiratory membranes. Again, simple squamous epithelium in the lung, ciliary endothelium, which is basically simple squamous, and then a basement membrane between the two, which forms an exchange network. It's probably made of mostly alveolar connective tissue. All right, I think that'll do. Let's go here. So the pathway, let's not forget, I'm not going to go through this again, but the nature of it is that air comes in the nose, down the pharynx, think about your tissues and what's there, down the larynx, to the trachea, to the bronchi, to the bronchioles, to the alveoli. You should be familiar with this. Hint, hint, nudge, nudge. All right, how is breathing controlled? So this is going to be done by your lower brain centers, primarily the medulla oblongata and the pons. So medulla oblongata is a little, that's totally wrong. The pons is a lump that sticks off the front of the midbrain, and then the medulla oblongata is an oblong portion of the spinal cord that's kind of swole. Okay, so it's this bigger portion of the spinal cord that's the medulla oblongata, and the pons sticks off the front here. And you can also mix into this the hypothalamus, which would be just above this, but for our purposes, medulla oblongata and pons. Okay, medulla oblongata and pons. The way that we tend to think about this is that the medulla oblongata is in charge. Okay, the medulla oblongata determines when you're going to breathe pretty much exclusively. The pons simply plays a role in gently regulating that activity. So you're going to hold your general resting breathing to about 12 to 16 breaths per minute. Okay, and not to be a huge downer, but you probably have heard of SIDS, or sudden infant death syndrome. We believe that this is when the brain stops sending respiratory messages down to the diaphragm. So the kid stops breathing just randomly, dies in their sleep. It's terrible, and absolutely terrifying for a parent. So if I were you, if you are planning to have a child soon, or if it's just sticking to you at this moment, you should totally go look up sudden infant death syndrome and look at ways of decreasing the likelihood of this happening. It goes all the way from keeping a kid in the room for a period of time where they can kind of hear you jostling around, and all the way to crazy blood oxygen monitors that you can buy that go on the kid's ankle, and if the blood oxygen levels start to change, an alarm goes off and tells you the kid's not breathing. You wouldn't believe it. They make all kinds of things these days. This is a terrible situation and something that you should be aware of. And this nervous control, using the medulla oblongata, using the pons, it's going to be getting information from this midbrain area and from chemoreceptors located in the aortic arch. Okay, what's really happening here is very simple. When the body has too much carbon dioxide, the blood becomes acidic. And when the blood becomes acidic, there are pH sensors that pick this up, both in the midbrain and in the, well, really in the hypothalamus specifically, and in the aortic arch. And you're going to pick up this pH change, and it's going to stimulate for breathing. All right? When the blood gets acidic, specifically when the brain gets acidic, the brain is really the story here. We're going to be testing blood in the brain, and when the brain starts to pick up too much acidity in the blood, it knows that it's time to breathe. So you're going to start breathing. Again, carbon dioxide increases or makes the blood become a little bit acidic, which decreases its oxygen carrying capacities. So we breathe to get rid of that carbon dioxide. Yeah, that'll work. Let's see, more neural controls. So I go into a little bit more detail here about the medulla oblongata and the pons. There's basically 3 respiratory centers. You don't have to know this, but I'll tell you. There are the ventral respiratory group, dorsal respiratory group, so dorsal and ventral. It's going to be in part and parcel with the medulla oblongata down here. And then in the pons, you have this pontine respiratory group. The reason I'm pointing this out mainly is just to talk about the phrenic nerve, okay, and the intercostal nerves, but the phrenic nerve primarily, and the way it comes down and innervates the diaphragm, because I had this beautiful picture of phrenic nerves coming down and innervating the diaphragm. So there's a real diaphragm, there's real phrenic nerves coming down and connecting and leading to that muscle flexing. Okay, I took this picture at a bodies exhibit in North Carolina, and I had to share it with you because I find it fascinating. So there's the phrenic nerves. They're going to be descending from the ventral respiratory group and playing a role there. Yeah. Okay, I will mention this. So inspiratory activities and expiratory activities. So inspiring, to breathe in, is a short process, about 2 seconds in regular breathing. And then when you exhale, you're basically just relaxing. So exhaling takes longer, about 3 seconds. So if you kind of pay attention to this, 2 seconds in, 3 seconds out, and in a minute, it's about 12 times. So yeah, generally speaking, this is all regulated by blood pH in the brain. Now, what the heck does the pons do? I said over here, where am I at? That the pons sort of assists in the process here. One of the things that makes the pons and its pontine respiratory group kind of neat is it helps us adapt to special situations. Like when you're asleep, you can change your breathing rates. When you exercise, you have to increase your breathing rates. When you are speaking, you have to change the way that air is exiting. So this is all going to be done by the pons. And then general emotional responses. So you've seen people can't get the words out. That's classic pontine respiratory group activity, regulating how air comes out and being augmented by your limbic system, which deals with your emotions. Let's keep on going. All right, good enough. So look at those phrenic nerves, man. Beautiful. Let's see. Are we happy with this? Oh, I'll mention voluntary control. So if I'm just sitting here talking to you about breathing, you're sitting there breathing, not thinking about breathing. Say that 4 or 5 times. But the nature of it is that you breathe naturally without having to think about it. But if I ask you to take a deep breath, you can do it. So you have voluntary control using your frontal lobe. So your frontal lobe is your voluntary control center. You can decide to breathe in or breathe out. It actually bypasses the whole brainstem area and goes straight on down. But there are limitations to this. Okay, at the end of the day, your midbrain controls things. Okay, your pons, your medulla oblongata, specifically the hypothalamus, they control if you breathe or not. So there's this classic joke of like a little kid tries to hold their breath to get their way, and my comment to you is, let them. They're going to hold their breath, it may pass out, and then they're going to start breathing, because the brain isn't going to let you die. It's going to make you breathe. You can't compel it not to breathe. You're going to breathe eventually. So tell them to suck it up, buttercup, and get tough. Going to breathe eventually. Fortunately, I've never seen this personally, but I have heard of it. All right. 2 phases of breathing, of general, what we'll call ventilation. Okay, your book would call this process ventilation. This is going to be inspiration and expiration, and this is as simple as it sounds. Inspiration is the active process, about 2 seconds of bringing air in. The nature of this is you flex the diaphragm and it pulls air in. You flex your intercostal muscles and expand the chest. You flex your sternocleidomastoids even and open the chest cavity up. And what this does is it pulls air in, like a syringe, man. You pull down on that syringe and it pulls air in. Now, the diaphragm and the pumping action of the diaphragm, as you can see here, is a nice magnetic resonance functional MRI showing the movement of the diaphragm like a piston-like motion. The diaphragm accounts for about 2/3 of the movement of air. Your intercostal muscles and all the other accompanying muscles, they take up that extra third. Okay, so about 2/3 of this is diaphragmatic, and then about 1/3 is going to be elsewhere. And the reason I mention this is because at some stage in your life, you've probably had the breath knocked out of you. Now, what the heck does that mean? Do I have a picture of a human anywhere around here? If I had this person and I gave him a good punch, pow, right below the xiphoid process, all right? What you're going to do is you're going to shock what's called the solar plexus, and what that does is it sends the diaphragm into a spasm. It knocks the breath out of you. Man, let me tell you, I remember one time playing baseball, getting hit right below the darn xiphoid process with a baseball, and you laying there on the ground going, can't get the air in, you're just dying, man. And the reason for that's very simple. When this happens, it shocks the diaphragm, and the diaphragm goes into a spasm. So you lose 2/3 of your capacity for breathing. So the only breathing you can do are short little sharp breaths, using your intercostal muscles and other accompanying muscles, and they allow you to get air back in. After a few minutes, this tends to settle down and you get to breathing correctly again. But it can be a pretty not fun situation. And that first time it happens, it's no fun for anybody, man. It's a terrible thing. Yeah, I think that's good. So that's inspiration. And then we have expiration. A passive process, takes about 3 seconds. You just relax. You relax your muscles and it lets the air out. The nature of this is when you flex your muscles, there becomes a low pressure situation inside of the lungs, and that low pressure situation pulls air in. And then when you relax and everything goes back to its resting state, it increases the pressure inside of this cavity and pushes the air back out. Again, remember your respiratory pump, moving blood, moving lymph. This action of expanding the chest and then decreasing the size of the chest pulls air and other things into the chest cavity and then lets it back out comparatively. Yeah, it's all about pressure, folks. It's all about pressure. You decrease the pressure in here, you're going to pull air in. You increase the pressure in there, you're going to let air out. And speaking of the movements of air, we can very precisely measure your lung function using a tool and or setup referred to as spirometry. They're very simple tools. It's like a little thing. You blow through it and it measures the amount of air you can exhale, and using this knowledge we can build a little chart like this. So right now, as you're sitting there learning about breathing, you're doing what's called tidal breathing. You know, think about the tides. Tides come in, tides go out. Tides come in, tides go out. It's tidal breathing. Small amounts of air that move in and out with each breath. 2 seconds in, 3 seconds out. Simple process. But then, if you wanted to, you could take a deep breath. You could go, right, really fill your lungs up. And you could feel the tightness in your chest as a result. That would be called an inspiratory reserve volume. Okay, an inspiratory reserve volume, the maximum amount of air you can take in with the deepest breath you can take. And then, if you wanted to, when you're just tidally breathing, doing what you do at a nice resting state, you could, if you so chose, forcefully exhale and remove all the air you could from your lungs. And that would be your expiratory reserve volume. So I can go and really exhale. All right, and that would be an expiratory reserve volume. We can measure this. Now, what we'd like to do is and let me say this before I move forward. This residual volume, there's always a little bit of air left in your lungs. You can't just collapse the lungs. Okay, that ain't the way this works. So there's always a little bit of air left. It's reserve volume. Now, what we like to do to measure general lung function is we tell you to take as deep a breath as is physically possible and then exhale forcefully through the spirometer, and we measure what's called your vital capacity. Okay, vital capacity is the maximum amount of air you can move if you so choose. So maximum volume of air that can be moved in plus the maximum amount of air that can be moved out during a single breath. So if I take as deep a breath as possible, and then I exhale as forcefully as physically possible, that's the maximum amount of air that my lungs can move. That's my vital capacity. And what you'll find is that your general health is going to vary directly with your vital capacity. So healthy individuals like athletes tend to have a really high vital capacity. If you sit around all day working on lectures, day and night at 2 in the morning, you're going to have a low vital capacity. Yay! Let's go here. Gas transport. So you're going to move gas primarily. Well, that's not true. We need to talk about hemoglobin first, and then we'll talk about this process. So hemoglobin is a molecule, binds 4 iron atoms, and it's going to be involved in your red blood cells, and it's going to be involved in your red blood cells in carrying oxygen. So hemoglobin is capable of binding oxygen, and it's found in your blood cells. So oxygen moves almost entirely bound to hemoglobin, okay? Bound to that iron. Your red blood cells contain lots of hemoglobin, ergo they carry the oxygen. Carbon dioxide, that ain't the way this works. Carbon dioxide does not travel with your red blood cells. I mean, it uses your red blood cells sometimes in ways I'll talk about in mere moments. But generally speaking, carbon dioxide travels as bicarbonate in your plasma. Okay? Bicarb. Travels as bicarb in your plasma. A small percentage by comparison is going to be involved with hemoglobin. So the way this works is a neat process. Remember, this is all diffusion based, but it goes as follows. You have in your red blood cells a enzyme called carbonic anhydrase. Remember, this is an enzyme, ends in ASE, carbonic anhydrase, and carbonic anhydrase in your red blood cells will convert carbon dioxide into carbonic acid, basically, but it ends up being bicarb. Okay, at the end of the day, we're making bicarb. Goes through a couple steps. It's all catalyzed. You can think of carbonic anhydrase as a catalyst that turns carbon dioxide into bicarbonate, so it can travel in the blood plasma. So this actually happens in the red blood cells, but then the red blood cells will offload that bicarbonate, and it flows around in the plasma. Do I want to talk about anything else? Let's talk about carbon monoxide just real quick because it's terrifying. So carbon monoxide is scary, man. Carbon monoxide, this is a byproduct of poorly burned fossil fuels, matches, what have you, gas leaks, you name it. The classic example is folks are freezing cold, the power goes out, so they get a space heater and they lock themselves up in their closet, and then the next day they're dead because the space heater burned off a bunch of gas in a bad way, released carbon monoxide, and there's plenty of oxygen in the room, but carbon monoxide has a really high affinity for hemoglobin. Okay? Oxygen loves hemoglobin. Carbon monoxide is in love with hemoglobin. You catch my point here? Carbon monoxide really, really, really loves hemoglobin. So when carbon monoxide's in the environment, it will bind up the hemoglobin and prevent you from carrying oxygen. So even if there's plenty of oxygen in the environment, if there's carbon monoxide, your hemoglobin will get bound up and you're not going to be getting oxygen to your tissues. It's terrifying, man. So if you got, gas in your place, having a carbon monoxide detector, not the worst idea you've ever had. And then we need to kind of break down the concepts of external respiration and internal respiration. This is all about pressure, moving gases. The nature of this is very simplistic. External respiration, this is going to be what happens in the alveoli, the lungs, and the blood capillaries. Internal respiration is what happens with the capillaries and the tissues. Okay, so this is happening out in your body. This is systemic circuit. This is pulmonary circuit. Pulmonary circuit, systemic circuit. Pulmonary circuit, systemic circuit. And the way this goes is as follows. When I breathe in, there's more oxygen in the air than there is in my blood. So oxygen diffuses into my blood. There's more carbon dioxide in my blood than there is in the air. So carbon dioxide diffuses out of the air and into the alveoli. All right? That is classic external respiration. Whereas what happens at your tissue level, right? So for instance, in my muscles, blood comes in that's bearing oxygen. My muscles use the oxygen and then offload carbon dioxide. So the muscles are in oxygen debt, so they take in oxygen and they're releasing as a byproduct carbon dioxide. So carbon dioxide goes back into the bloodstream, again being converted into bicarbonate in your red blood cells using carbonic anhydrase. And I'm pretty happy with that. I'm not terribly concerned. All right, let's see. I have a point to this slide. What was it? My plan is to go into more detail on this in the future, so I included the big chart here. But what I want to talk about is this. The nature of how quickly gases can diffuse is that as this happens in your cardiovascular network, the process happens very quick. Okay, it's a very fast process. Let's see how I give you precise numbers. About a third of the time, blood spins in pulmonary capillaries. The nature of it is that blood can flow 3 times faster than it normally does without losing efficiency. So what I'm saying is that your rate of diffusion is incredibly fast. All right, we can diffuse these gases very quickly indeed. In fact, you could move blood through your cardiovascular network about 3 times faster than it does, and you would still efficiently move oxygen and carbon dioxide. All right, worthy of mention here is that there's a really steep concentration gradient when we're playing with oxygen. So the amount of oxygen in your bloodstream is very low when it comes to the lungs, whereas the amount of oxygen in the air you breathe in is incredibly high. So there's a big concentration gradient, like shoving that oxygen into your bloodstream, okay? Whereas the amount of carbon dioxide which you exhale, the amount of carbon dioxide that is coming into the lungs with the blood, the gradient there is pretty weak. There's just a little bit less carbon dioxide in the atmosphere, so carbon dioxide diffuses out of your blood into the atmosphere. Let me say that again for clarity. there's a lot of oxygen in the air you breathe in, but very little oxygen in the blood that comes to the lungs. So there's a really steep concentration gradient that shoves the air into the blood. Whereas carbon dioxide, having to diffuse out, there is still plenty of carbon dioxide in the air, and the gradient is very slim. So there's just a little bit less carbon dioxide in the air compared to what's in the lungs. So carbon dioxide diffuses out of the blood into the air around us. It's a very weak concentration gradient. And as a result of this, it could be excused to think that more oxygen moves than carbon dioxide, but in reality you have about equal parts of oxygen and carbon dioxide that exchange every time you breathe. And the reason for that is because carbon dioxide is incredibly soluble in terms of the fluids and the surfactants in your lung tissue. So it's very easy for carbon dioxide to move, where it's a little harder for oxygen to move. So you move about equal parts oxygen and carbon dioxide. That's the idea here. So you're constantly exchanging these, and you're moving them in roughly equal parts, because carbon dioxide, even though it's got a weak gradient for movement, a weak diffusionary gradient, it's really good at diffusing. It's very soluble as a gas. Yeah. And last but not least, let's talk about some disease-based issues. So your upper respiratory tract, you can have a variety of issues here, and I'm not going to go into a whole lot of detail on any of this. Sinusitis, inflammation of the sinuses can lead to blockages. Good old-fashioned otitis media, it's a middle ear infection, the bane of young children that cry a lot and drool into their ear canals. Tonsillitis is an inflammation of the tonsils. These can swell up, as we talked about in the lymphatic system. And then last but not least, good old-fashioned laryngitis. So you've, oh man, right when COVID hit, I got laryngitis. And I was walking around sounding like absolute death. And everybody thought I was dying with COVID. Oh, worst thing you've ever seen in your life. It's just where the larynx gets inflamed and it doesn't vibrate correctly, so your vocal cords don't vibrate in the way they're supposed to, so you end up losing your voice until they kind of lose that inflammation and go back to normal. Good old-fashioned laryngitis. And then there's a whole variety of lower respiratory tract issues. Bronchitis, so you get some sort of inflammation inside of your bronchi, and they start to swell, and they weep out fluid, and they can get inflamed with bacteria and produce pus and gross, and you're coughing up junk all the time. That's bronchitis. Okay, good old-fashioned bronchitis. Asthma, you come into contact with some sort of allergen, and your bronchioles, which have a lot of smooth muscle in them, constrict. When you constrict your bronchioles, that limits your ability to move air in and out of the lungs, and you can die from it, man. It's scary stuff. Emphysema, which we talked about previously, typically a side effect of smoking. This is where the air sacs of the lungs break down, and instead of having individual air sacs, you have this one big circle, one big air sac. So you lose surface area, and you lose oxygen diffusing characteristics as a result of that. Tuberculosis is worthy of mention here. This is where we get a bacterium into our lungs, and that bacterium gets encapsulated in like a big macrophage, but you can't kill the bacteria. So you just end up with these tubercles, these spots of bacteria hanging out in your air sacs of your lungs, trying to protect the white blood cells, are trying to protect you from the bacteria, so this hold them in place. And these are tubercles. They limit oxygen diffusing capacity just by taking up space and reducing general elasticity. Tuberculosis. Pulmonary fibrosis. You can inflame the lungs in a variety of ways and lead to the lungs laying down, in essence, what is scar tissue. All right. They lay down a bunch of fibers, and those fibers wrap around the alveoli and prevent them from expanding. That's pulmonary fibrosis. And then, of course, there's pneumonia. Pneumonia is where the air sacs of the lungs fill with fluid and pus and gross, and they can get inflamed. And when they are full of fluid, they don't diffuse oxygen very well at all. So that's good old-fashioned pneumonia, okay, filling the alveoli with fluid. And then, of course, there is lung cancer, okay? Any uncontrolled cell division in the lungs, oftentimes caused by smoking. Now, holy text, let me tell you. I don't really prefer to read to you guys, but I'm about to read to you, because this is like my big public service announcement. All right, let me get up on my soapbox and lay this on you. These are facts about tobacco you should be aware of. All forms of tobacco can cause damage, okay? And that damage could lead to cancer. Cigarette smoking causes, oh, I should have checked my numbers. This is a couple years old. It's way more than that now, I bet. causes more than 480,000 deaths a year in the United States. That's 1 in 5 people that die because they've been smoking and have gotten lung cancer as a result of that. This is the leading cause of death in both males and females. I think this is the leading cause of death? Don't quote me. Don't quote me. It's a huge killer, though. That's the idea, okay? Massive numbers of people. More than 10 times as many U.S. citizens have died as a result of cigarette smoking than have died in all wars fought by the United States in our entire history. Smoking causes about 90% of all lung cancer deaths in both men and women. Okay, so smoking causes lung cancer. And here's an interesting one. More women die from lung cancer every year than they do from breast cancer. You know, we got all these holiday things set up. We wear our pink ribbons. But the reality is way more ladies are dying from smoking. So our big public service announcement should be to freaking not smoke so you don't die of lung cancer. All right? Smoking increases a person's chance of lung, mouth, larynx, esophagus, bladder, kidney, pancreatic, stomach, and cervical cancer. Smoking increases the chances of chronic bronchitis, emphysema, heart disease, stillbirths, and general harm to an unborn child. Passive smoking, i.e. secondhand, can increase a non-smoker's chance of pneumonia, bronchitis, and lung cancer. And if you get lung cancer, I'm going to go ahead and tell you that prognosis is really poor. Lung cancer tends to spread super fast. Okay, normally by the time you notice you got an issue, it's already into your lymph nodes, it's already in your liver. It'll spread to the pericardial sac. It moves very quickly through the system. So only about 7% of patients who have lung cancer survive 5 years. Okay, so it's very, very super scary. Let's see. Smoking increases the risk of strokes by 2 to 4 times, coronary heart disease by 2 to 4 times, of men developing lung cancer and women for about, it's the same, about 25-time increase. So that is to say that if you want to live to see your grandkids, you should probably consider not smoking. All right, so that's the end of the respiratory system, and I believe it's time for the next exam. So if I were you, I'd be studying. Have a good day, guys.